So it's a good evening or good afternoon for everybody. Thank you for making the time to join this presentation by Dr. Ammar Safar. Dr. Ammar Safar, he is the medical director of Moorfields Eye Hospital, UAE. Moorfield has got branches in number of places, among them London, Abu Dhabi, Dubai. So Dr. Ammar Safar, he is the medical director of Moorfields Eye Hospital in UAE. He is a professor of ophthalmology at the Mohammad bin Rashed University of Medicine and Health Sciences. He has practiced medicine and holds a certificate from Cornell University, US. He has also served as the president of medical staff at American Hospital Dubai. I don't know how many of you know, it's one of the premier hospitals in Dubai. He is American Board-Certified in Ophthalmology and is highly experienced consultant in Vitreoretinal Diseases and Surgery. He brings over 20 years of experience and was trained in the Georgetown University in Washington, D.C. and the University of Texas, Southwestern Medical Center in Dallas. So, Doctor, we are very proud to have you, and we thank you for taking the time, in spite of your busy schedule, to give this audience a brief about the subject that we are going to talk about today. Thank you, Doctor.
Thank you so much, Mr. Ashok. I really appreciate the invitation and taking the time to invite me today. I'm very, very happy to be with you guys. I'm going to try and share the screen here, if you don't mind. 1 second. And then we can go ahead and proceed. So I just want to ask for some confirmation from anybody who's attending. If you can just tell me if you can see my slides.
Yes, sir, we can.
Excellent. Thank you so much. So again, thank you so much for the opportunity to be with you and for giving me the time. So just for time purposes, how long do you need me to speak? Because I want to allow some time for any potential questions and answers.
Doctor, around 40-45 minutes,
okay.
And then let us give it to the public to ask questions.
Perfect. Excellent. So first of all, I'd like to start with a small video, hopefully that will introduce you to Moorfields. So let me just have you run that.
Hello everyone, welcome to Moorfields Eye Hospital Dubai. We'll give you a private tour of our hospital before everybody comes in. Follow me. Moorfields has been in the healthcare city here in Dubai for over 12 years. But we come from a very rich heritage of over 200 years in the eye care industry, taking care of eyes and providing care throughout all levels of the spectrum of the eye care. This here is a very good glimpse of our history as you walk into the hospital. Let's keep going. In this department, patients start by seeing our nurses and get evaluated, and then they get their photography done for their eyes. Then they actually consult with the doctors and make decisions on their eye care. Welcome to our Pediatric Ophthalmology department. Here we have a full team of professionals from doctors, orthoptists, and optometrists taking care of our kids and their eye health, from the smallest problems all the way to the advanced cases. So here is where the magic happens. This is the surgical department where over the years we have completed thousands of very successful surgeries. A lot of them were actually done for patients who came from outside the UAE to seek the expert opinion of our surgeons. Let me just give you a quick sneak peek. Come with me. Behind are 3 operating theaters, 1 for LASIK and refractive surgery, and 2 for more complex intraocular surgery. Here at Moorfields, we don't only offer excellent and outstanding medical and surgical care, we also cater to our patients' needs. And this might be just glasses or contact lenses. Behind me, you can see an optical shop that actually offers this, and patients have been really having very good experience with that. In addition, we have a full pharmacy that offers all the medications needed for eye care. Thank you so much for joining me for this very quick tour. It's a busy day in the hospital, and I have to go. Thank you so much. Have a great day. Bye-bye.
All right. So this is just an introduction of who we are, where do we come from. I just want to also quickly tell you that Moorfields Eye Hospital in London is the mother hospital, obviously. It's a world-famous institution in the world of ophthalmology, and we are proud to be the one and only branch of Moorfields Eye Hospital outside the UK. Opened in 2007, and this year we will be celebrating 15 years in our existence in Dubai. We're branching out, as was mentioned earlier, and we've opened another branch in Abu Dhabi in 2015. And even here in Dubai, we're already opened 2 branches additional to the main, and planning on opening another 2 to 3 branches within Dubai and the Northern Emirates. So having said that, now we're going to move to the presentation. And the presentation today will, from a medical standpoint, we'll try to tackle 3 major conditions that we face here in the Gulf area and actually around the world. The first one is diabetes and its effect on the eye, or what we call diabetic retinopathy. The second thing we will talk about will be cataract, which is a very important topic in eye health. And the third one will be retinal detachment. So I'm going to try and spend most of my time discussing these 3 conditions, and then we will allow the last about 15 to 20 minutes to hopefully get some questions and answers if you have any of them. So diabetes obviously is really an epidemic, unfortunately. It's a global epidemic, and the main problem causing it is obesity. So the obesity or the increased weight is causing the body to not be able to, use the insulin produced by our bodies, and unfortunately our sugar goes up. So this is causing diabetes to shoot up in the incidence across the world. And if you look at a world map, you can see, and this is information only from 2013, things have actually increased a lot. And you can see how millions and millions of people are affected by this very dangerous condition. In the United States, where I trained and lived for 20 years, patients actually, you can think about it, 1 in every 3 patients will have or develop diabetes in their lifetime if they live long enough. Now, diabetic retinopathy is a condition caused by the diabetes. And the patients with diabetes, if you look at the entire population that has diabetes, about 1/3 of them actually will develop eye problems. So when you look at all of these millions and you look at the percentage of patients that would get diabetic retinopathy, this is actually a huge problem for vision. So the main part that the diabetes affects in the eye is something we call the retina. And this is a picture we call OCT, which is a cross-section of the retina. And you can see here that this is a normal retina, has no effect from diabetes and no swelling or no increase in the thickness. While if you compare it to the next picture, which is this one, that's called edema or swelling of the retina. And this is a typical picture of what you would expect to see in a patient who has diabetes, who had a problem in the eye from the diabetes. Now, we call this, like I said, diabetic macular edema, and this is one of the most common causes of vision loss in patients who have diabetes. It affects 7% of the entire diabetic patients, and the prevalence in the United States, at least, is quite big, as you can see here. About 26 million people affected in this condition, and 24,000 new cases of blindness annually is caused by this condition. And about, like I said, 35% to 40% are still, unfortunately, underdiagnosed with this condition. So from I get asked this question a lot. What does diabetes have to do with eyes? Why does diabetes develop a problem in the eye? Well, diabetes is a condition that affects the entire body. It actually affects the vessels of your body. So if you think about it, every part of your body will have blood vessels, because that's how we get our oxygen to our parts of the body. So if the diabetes is actually working on creating problems within the vessels, then every part of your body actually is susceptible to having the effect of diabetes. Unfortunately, the eye, given the fact that it's very, very rich in blood vessels, is the one that is very vulnerable. Another very similar organ in our body is the kidney. So that's why you always see people who have kidney problems from diabetes also experience having the eye problems from diabetes. Now, of course, as you can see here, diabetes duration is the most important part. So how many years have you had diabetes? Very rarely would you see any problem from diabetes if you just had it diagnosed a year or two ago, unless it was there but undiagnosed and undiscovered. But if you're checking and you don't have diabetes, and then you develop it, then unfortunately, if you don't really take care of it, it takes 5 to 10 years before you start having issues in the eyes and in the kidneys and elsewhere. The hemoglobin A1C basically is something that we check every 3 months to know what is the appropriate control or not. So is your sugar well controlled or not? So if your hemoglobin A1C is well under normal levels like 5 to 6 or 6.5, then you're fine. But if your hemoglobin A1C is 8, 9, or 10, or even above 10, then that means you are not well controlled, regardless what your morning sugar is. Now, those factors here, the high blood pressure, the ethnicity, African individuals more than Caucasians, dyslipidemia or having high cholesterol are all called enhancers. They increase the effect of the other two factors. And all of these, unfortunately, lead to the development of what we call diabetic macular edema. As you can see here, this is a bit more technical. This is the pathophysiology of what happens on the cellular level. But the really important thing that you need to understand is that the problem is at the vascular level. So there is basically a problem that is happening in the vessels, causing them to become leaky. This is the cross-section of the vessel. And as you can see on the left side, this is normal. So the blood will pass by without having any problem. While here, you can see that the vessel became abnormal, and then you start actually leaking fluid as the blood is passing by. And this fluid causes the swelling that you saw in the picture. This is obviously a very, very busy schedule slide. I'm not going to actually go over it in detail, but I'm going to just show it to you so that you understand how complex what's happening in the eye is and why we need to really address this problem. So we are very lucky because we are living in a time where things have changed significantly. Hello? Yeah. So things have changed significantly over the years because for decades we had really no treatment for this condition other than laser. And laser, unfortunately, was not very effective. While recently in the 2005, 2006, we had these medications introduced into the market called anti-VEGF, which are basically a class of medications that treat the effect of diabetes on the eye. Bevacizumab is one of those medications. And this here is another medication, mainly is composed of what we call steroids or cortisone. So those medications are injected in the eye. And this is trying to show you that bevacizumab blocks only one thing, while basically the other medication called triamcinolone acetate blocks the entire factors that are responsible for forming the problem with diabetes. So how do we treat them these days? We treat them with injections that we apply inside of the eye of these medications that reduce the presence of the bad factors produced from the diabetes, and that results in resolution of that swelling that you saw, which results in restoration of the visual acuity of the patient. And like I said, there are so many medications, as you can see here. Onto your left, there is something we call anti-VEGF agents. Some of them called ranibizumab, aflibercept, bevacizumab. These are basically the ones available right now. And to the right, you have the steroids, which are basically Ozurdex, Iluvien, or medication called the Kilon. So those are the injections that we use right now in order to treat patients with diabetes. Of course, laser is now fallen completely out of favor to treat that swelling. But surgery, we still resort to surgery because we do have very advanced cases when it's not only swelling, but rather you have also bleeding inside of the eye or scar tissue formation inside of the eye that has caused contraction and pulling of the retina. In these cases, we go ahead and do the surgery. So initially, the first line of therapy right now for diabetes is these injections, and they are very, very effective. And we start with the anti-VEGF therapy, which is safe, has really little to no side effects, and they really give very, very good outcome as far as recovery. Now, they are sometimes, of course, nothing works 100%. If they do not respond, then at that point, you add the second role, which is the presence of the steroids, which can actually take care of the inflammation that happens in diabetes and then take care of the swelling that you see. Ozurdex is one of those implants. It lasts for a long time in the eye, for 4 to 6 months almost, and it's a very powerful tool to take care of this problem. And it is also safe, but it can cause, in some people, about 15 to 20%, can cause some elevation in the pressure. So you really need to think about when you see these patients, which medication do you really need to use? Are you using the VEGF or the non-anti-VEGF medications, such as the steroid, and try to balance between them in order to give your patients. So no, really there is no one size fits all in diabetes. You have to really look at these things and find out which one do you potentially can use. And sometimes you use a combination of both of them. I'm just going to share one case here. A patient, 61-year-old male, presented with poor vision in the left eye for 3 months, history of diabetes, high cholesterol, and no diabetes, history of hypertension, and supposedly no diabetes. So when you look at that guy, you see this severe swelling in the retina. So this patient, as you can see, has this massive, like I showed you in the previous picture, massive swelling, and the need for injections here is very, very clear. So when you give the first injection and you see what happens afterwards, this is the same patient that went from very swollen retina, I'll go back, to a very normal looking retina with one injection. And then you give the second injection to solidify the effect. And then basically you monitor these patients to see. So typically we can do sometimes 2 to 3 injections, because most of the studies show that doing 2 to 3 injections actually is what is the standard of care to get the most amount of vision. Now, sometimes what happens is after you give multiple injections and then you stop, the patient unfortunately gets a recurrence. Like this gentleman had a cataract surgery and then he started having another episode like this. In this case, you go like, okay, what do I do at that point? Do we continue with the same injections, or do we shift to something different? And in this case, what we need to do, in my opinion, is to shift to something different, specifically the steroid, because A, it is less frequently. Instead of monthly injections, you can go to 4 to 6 month injections, giving more time for the diabetes control to set in and give you the control. So like I said, always we think about these options, trying to not box ourselves in routines, but rather try to think outside the box of potentials to improve the patient's condition, and use the scientific data that we have available for us and the most updated data in order to be able to hopefully give the patient the best possible outcomes. Now, I'm going to move on to the next topic, which is retinal tears and retinal detachment. So the retina, let's start with the definition first. What is the retina? The retina is the innermost lining of the eye. It's a membrane that lines the inside of your eyeball. And if you remember from the years ago, it is basically the area where the retina, where the vision is created. So if you remember from years ago, when we used to have not digital photography, but actually film photography, the film, which is the sensitive part, used to be in the back of the camera, and then you have a lens in the front of the camera. So the light goes through the lens, gets focused on the film, and you get a picture. So the same idea, the camera actually is stealing this idea, if you will, from the eyeball. So the eye is like a camera. There is a lens in the front, and then there is a retina in the back, which is the sensitive part where the vision is created. Now, of course, the retina depends on blood supply to get its oxygen, and that comes from two sources: the layer underneath it, we call it choroid, and also from its own vessel that is right over here. Now, the separation between the retina and the wall of the eye for any reason is by definition what we call retinal detachment. So as you can see here, for example, in this picture, the retina has actually been pushed forward, and there is a space now between the wall of the eye and the retina, and we call that a retinal detachment. Now, how can this happen? How can a retina separate from the wall of the eye? What are the causes? One cause is if you have what we call fluid overload. So if there is, for any reason, there is increased fluid production from the cells underneath the retina to the point that the eye cannot keep up to get rid of that fluid, then you develop a bubble underneath the retina, and we call that a retinal detachment. This is one example. So you can see here that there is a bubble, and that bubble is fluid caused by a problem, which is that white area. And we don't really need to go into what the problem is, but I'm just trying to explain a concept here. So you have basically this problem that is producing too much fluid, exactly like this fire hydrant is pouring fluid into the street, and this cannot be taken out efficiently by the eye, so it creates that bubble. This is an example of a condition, medical condition, we call it central serous retinopathy, and this is typically happening in young individuals who have a lot of stress in their lives, that you get this area where it starts to leak. And once you have that leakage, the fluid accumulates underneath the retina and pushes it forward. And luckily, this is a condition that gets better by itself. Another problem, or another example, is that happens in older individuals, is called macular degeneration, where you have a collection here of abnormal vessels. Those abnormal vessels are so leaky, and they start to leak all of the fluid from them, and you get the accumulation of fluid underneath the retina, which pushes it forward, giving you what we call serous retinal detachment. Okay? So let's move on to these are also examples, but for the sake of time, I'm going to keep going. Another cause, instead of fluid overload, is traction or pulling on the retina. Anything that accumulates on the surface of the retina and pulls it can cause a detachment of the retina. This is an example of a retina that's being pulled on. This is the retina. It should be like this, sitting over here. This part should be sitting over here like the other part, but something is pulling here, causing this retina to separate. The typical scenario here is diabetes. Again, if you remember, I told you sometimes we have scar tissue formation in diabetes that pulls the retina and creates the detachment. Another thing, these are, for example, babies who are born prematurely also can have the formation of scar tissue and cause them to actually pull. There is a condition that is actually quite common in Africa and the Middle East also, called sickle cell disease, which can also cause scar tissue and pull on the retina. This type is usually slowly progressive. So it's not the acute type that all of a sudden causes vision loss. This is rather a type that causes a very slow vision loss, and sometimes it bleeds, which can make things happen faster. The third cause for a detachment, which is actually the more common and more acute, is to have a hole in the retina. So if you have a hole or a break within the membrane that we call retina, then fluid can find its way and go underneath the retina, pushing it forward and causing it to detach. So this picture or this drawing is an example of the jelly inside of the eye. We call that vitreous. That jelly is pulling on the retina, causing a break, and then fluid finding its way to go underneath it and cause it to detach. So this is something in English we call regmatogenous retinal detachment. It's a very big word. It's called regmatogenous. Regma in Greek means break. So regmatogenous means it's caused by a break. So it's a detachment of the retina caused by a break. This is a clinical picture of a break in the retina. So that is what we were trying to draw over there in the previous slide. You can see that this is actually a break in the retina, and the fluid has gone through that and caused this part of the retina here to actually detach or separate. This is one of the most common forms of retinal detachments, and it is considered an ocular emergency because when the detachment of the retina starts to happen, the time is ticking. And you really need to get it fixed as quickly as possible in order to get the best visual outcome. And it really does make a difference with the visual outcome, how big the detachment is, did it reach the center or not, and how long has it been there for. So it affects 1 in 10,000 people a year. So in the UAE, approximately, you have 700 cases in the UAE, approximately 58% per month. So 58 cases per month, all throughout the UAE, if you look at the population. It affects all the ages, usually peaks between 60 and 70, but you frequently see it in younger individuals, and it does, for some reason, affect men more than women and white individuals more than Africans. Now, what are the symptoms of it? Sudden, painless loss of vision. So the patient will not tell you it's hurting. It doesn't hurt. It doesn't cause pain, but it happens quickly, literally within hours sometimes. And if you sometimes go maybe not hours, days, but typically happens within hours, and people kind of ignore it and say, I'm just tired. I didn't sleep well. I was driving for a long time. They always try to get excuses for it. It will go away, but it never goes away. Once it happens, that sudden loss of vision, which looks like a curtain, it looks like a dark curtain that comes from either direction, can come from above, from the sides, from the below, depending on which part of the retina is detaching. It's grayish, blackish shadow that covers part of the vision and continues to progress. It is typically preceded by intense flashes of light and what we call floaters, which means dots, black dots or lines like cobwebs. Okay, not necessarily. Some patients don't notice the flashes of light or not notice the black floaters and the lines, but that's the typical story. And like I showed you in the drawing, the actual what's happening is that the jelly is actually pulling away and causing that full thickness tear in the retina, which causes then the fluid, gives access to the fluid to go to the space underneath the retina, as you saw in this picture before. What are the risk factors for retinal detachment? Who can get it more than others? As you can see, myopia is one of the biggest ones. Now, the higher amount of myopia, the more likely that you will get it. And what is myopia? Myopia is nearsightedness. So basically, if you have nearsightedness, requiring glasses because you don't see well for a distance, that's what we call myopia. And if you have -1, -2, it's not that bad, -3. But if you have -5, 6, or 7, then that's when you start getting into a higher risk of retinal detachment. Having something called lattice degeneration, what is that? That's basically just thinning of the retina. So it's a little bit too thin in certain patches of it, especially the peripheral part. That also puts the patient at a higher risk. Family history is a risk. So if you have somebody in the family, a father, mother, uncle, brother, somebody had a retinal detachment before, then there is increased likelihood for that person to have a retinal detachment. Also, previous history of previous surgery, such as cataract surgery, for example, or any other surgery in the eye, can potentially slightly increase the risk of retinal detachment. Having a detachment in one eye, unfortunately, causes the other eye to have a higher risk of detachment. That's all statistics. And of course, trauma, anybody that gets hit in the eye gets a risk of retinal detachment. How about LASIK? If people get LASIK, do they get actually retinal detachment after that? Not necessarily. Actually, this is something that's been looked at quite carefully and not found to be actually associated with in any specific increased risk of retinal detachment. But think about it: who gets LASIK? It's people who has myopia or nearsightedness, and they have that as a risk factor, regardless whether they get the LASIK or not. So how do we diagnose it? Typically, we diagnose it by looking at the eye, a patient examining the eye. We can see the retina directly, but if you want to document it, then you can get a picture that we call OCT, like I said, cross-section, as you have been seeing throughout the presentation. And you can see that part of the retina here is separated from the wall of the eye, while the rest of it is not. So this is a retinal detachment, and it does not involve the center, because the center is right over here, and you can see that this is, but it's very close to the center. So this is considered an emergency to fix as quickly as possible. So what's the differential diagnosis? You know, is there something else that looks like a retinal detachment but is not retinal detachment? Yes, and this may be beyond the scope of this talk, but I'm just going to quickly mention that. You can see here, for example, a bubble in the bottom part that looks like a retinal detachment, but it's not. This looks also like a retinal detachment, but again, this is not. This is called choroidal separation or effusion, and those things usually go away by themselves. So when you are managing a patient with retinal detachment, the first thing to decide or to consider is, do we have macula on or macula off detachment? And that means center of the macula, the center of the macula. Is it separated or not? Is it on, which means it hasn't separated yet, or has it come off? Why does it matter? Like I said, because of multiple factors. Number one, the macula on detachment, usually 90% successfully repaired, and patient's vision get very, very good, 6/12 or better. While if you have a macula off retinal detachment, 50% successfully repaired macula off get 6/15. So basically, you can see that the vision recovery in patients who have macula off retinal detachment is far lower than if it does never detached. So that's why it's very important when we see a retinal detachment that has not yet involved the center of the retina, that we fix it as quickly as possible in order to get the patient the best visual outcome. Now, how do we treat the retinal detachment? 3 ways of treating it. And but the principle for all 3 of them is the same, which is to close the hole. Okay? So we know we have a hole in the retina, and we need to close that hole. And there are 3 mechanisms we can try to actually close the hole. And that's actually the famous sentence that Jules Gonen came up with, which is closing the hole, the concept of closing the hole in 1920. So from that time until now, we do the same exact thing as far as closing the hole. So the goal, the surgical goal, is exactly the same. Now, the technology has improved dramatically, of course, from 1920 until now, because in the 1920s, there was nothing other than what we call, or even up all the way up until the 80s, there was nothing other than what we call a scleral buckle, which I will show you right now. So what is a scleral buckle? It's like the buckle you have around your waist. It actually squeezes the eye. You know how you want your pants not to slip down? You put that buckle and you tighten it around your belt to kind of hold it in place. Well, the same thing happens here. If you basically want to close the hole, then you indent the wall of the eye by putting a belt around the eye. We call it a buckle, and that actually pushes the wall of the eye to close this hole here, as it's happening right there. Of course, that people might ask, wow, ouch, this might hurt. Of course it hurts, not forever, but unfortunately for the first week or 2, it is quite painful. Another way of doing it is just to inject a small gas bubble in the office. And as you can see here, when you inject inside of the eye, a small expansile gas, which means it expands in size with time, then you inject it here, and within a few hours, it becomes a bigger bubble, and it closes that hole, okay? And then we go in the next day and put some laser around the hole, which kind of seals it off. And that gas bubble will be absorbed over a week's time out of the eye, and hopefully restore things. Now, as you can imagine, this could actually be helpful for patients who have tears that are in the upper part of the eyeball. But if you have a tear in the bottom part of the eyeball and you want a gas bubble to close it, then you're going to have to put the patient upside down, which is not practical. So it is an option. It is an office procedure. It takes about half an hour to do, and it basically can save the patient a trip to the operating theater, but it doesn't have the same success rate as the full-blown surgery, which is the next one here called vitrectomy, where we go in, we remove the jelly inside of the eye, and we aspirate the fluid from underneath the retina, which puts it back in place, and then we laser around it and put a substitute. Now, I'm going to, this is basically me in the operating theater. Yeah, we don't need this, we don't need the sound, but basically you can see where I'm using this is the latest technology we have, Ingenuity, which is really a very advanced device where I'm actually using 3D glasses in order to see, along with everybody in the room with me, and that lady that you saw behind me is a medical student from Mohammad bin Rashed University, where I teach, and working on the retina. We all see the same image. Sorry, this is a student right here. But what I wanted to show you is this video, which shows using the same technology. You see how this part is the detached retina here in the bottom part, and I'm indenting with my left hand, and at the same time removing that jelly and removing all of the traction that is present on the retina in order to close or be able to close the hole and get the retina back into place. Once we do that, we go ahead another technique now, which is aspirating the fluid. I'm sorry, this is dual, but you can see how I'm actually aspirating the fluid. That looks kind of different in composition. It's coming out of the subretinal space, and you can see the retina is just very, very naturally going back in its place and sitting where it needs to sit, with that fluid that looks like jelly is coming out of the eye. And then ultimately what we do is we put it later around this hole, closing it off, and that should take care of the problem. As you can see here, the retina has already been repositioned. So the retinal detachment, like I said, is a time-sensitive condition, especially if the macula is not detached. And it's very important to understand the pathophysiology, or the reason behind it is crucial really for the success of the treatment. And this is why it's very important to really diagnose the condition initially. And of course, anatomical success is quite high. Internationally, it's between 85% to 90%. Our numbers here in Dubai, actually, we audited ourselves, and we are close to 96% success rate with one surgery, which is what an international with multiple surgery. So with one surgery only, we are actually much closer to achieving the success rate for the surgery. Now, the next and last topic, with the last maybe 5 to 10 minutes, is going to be cataract. So I'm going to start by a typical presentation. 61-year-old male presents with evaluation of blurry vision in the right eye, had multiple changes of glasses. So every three times over the past 10 years, so pretty much 10 months, sorry. So over a small period of time, 10 months, he had to change his glasses 3 times, which is by itself a flag that this patient might be developing a cataract. And he said finally that even with the most updated glasses, vision is not good. When you look at this lamp, you can see that the lens of the eye, as you can see here, has the cataract. So the diagnosis here is quite clear, which the patient has a cataract. So what is a cataract? The cataract basically, obviously you can see here the Greek word for it, meaning waterfall, but basically it's clouding of the natural lens of the eye. And the natural lens of the eye sits basically right behind the pupil, so everything behind it gets fogged up because of the presence of that fogging in the cataract, of course, due to multiple factors. So it is a very, very common cause of blindness all throughout the world. 20 million people worldwide are blind due to cataract, and it is basically it is the cause of approximately 5% of blindness in the United States and nearly 60% in Africa and South America. Unfortunately, 60% of blindness is caused by cataract, which is really a shame, if you ask me. Anatomy of the lens. So the lens has a nucleus, has a cortex. This is really not a very important thing to remember, but I want you to understand that this is an age-related condition. So basically, anybody that is blessed enough to actually live long enough will develop cataract in their lifetime. So what are the risks? Diabetes, drugs, especially steroids, ultraviolet or sun exposure or radiation, smoking is a risk factor, alcohol is a risk factor, any nutritional deficiency like low levels of antioxidants, for example, vitamin C, E, and carotenoids, and also family history. Sometimes it runs in families that cataracts form earlier on in life. So how is the vision altered by the cataract? So if you have a lens that has become cloudy, of course, the vision is going to be dispersed all throughout instead of focused on the central part of the retina. So that's one part of how it is affected. And if you can see here an animation of what happens with cataract, you can see that on the right it is clear, while patients who actually have cataract will start to have difference in the color or even not able to see the details of what they are looking at. So spectrum of the cataracts, you have multiple kinds of cataracts. You have a cortical cataract, you have a posterior subcapsular cataract, you have a nuclear sclerotic cataract, and you can have what we call a cortical cataract, and you can have a Christmas tree or congenital cataract, and this is also another example of a posterior subcapsular cataract. This is more of a congenital or drug-related cataract. And of course, this is the mature cataract where things have closed completely. Now, cataract surgery is basically a surgery that replaces the lens of the eye. You have a lens that has become very cloudy, and you need to replace it. Okay, so there's no idea, thing about removing only the lens and not really implanting anything after it is really something that we still continue to struggle with right now, day in and day out. People ask, why do you really have to put a lens? I try to explain to them that to think back to their parents or their grandparents, where they used to do cataract surgery, they used to give them very thick lenses after the. Why? Because they need a lens, they need the power, but there's really no way of implanting a lens. But now we have a way of implanting a lens. And there is a very nice story behind it, which is in World War II. People have noticed that the sharpness that come from the aircrafts after they get hit with a, if some of that window of the airplane goes into the eye, doctors have noticed that these particles are made of PMMA and they do not actually cause any inflammation in the eye. So they took that idea and said, well, maybe we can use this material to create a lens that we can implant in the eye and make the eye tolerate it. And that's exactly what happened. And this is basically where the birth of intraocular lenses, and this is basically what a lens looks like. The optic here in the middle, which gives us the power, and those two small legs here is what keeps it in the anatomical place. So this is basically what happens with the cataract surgery. And basically, animation obviously here, as you can see, we make a small incision, and then what we do is we go in and try to emulsify or fragment this cataract with this little probe we call phaco probe, and this results in the aspiration of this material, and then keeping the capsule in place. Through the same hole, we implant the lens, and that lens gives the power to the eye. So that's basically, in an essence, what a cataract surgery is. Here you go, and now we have a very good image of the ball on the eye. And this video here, this is showing you modern cataract surgery. This is a very long video, but trying to go through it again. We making a small incision, and then we go in and try to make an opening in the lens capsule. As you can see here, the surgeon is making that opening so that you can access the lens. Once you make that opening, then you bring in the phaco emulsification. As you can see here, the lens is fragmented into small little pieces, and those pieces are actually being aspirated one piece at a time to evacuate the cataract from the eye. So the first piece, second piece, and then that results in total evacuation. Now, this is just a quick video I want to close with. It's a patient of mine. Rhexis is that opening we create, like I said in the beginning, which creates the opening to access the cataract. So this patient, I'm just going to give you a quick story about him, and then we can stop and get questions. So we start the surgery. We do the surgery usually under topical anesthesia, which means patient is awake. The minute we put the patient in the operating theater, he started to have a hiccup, and a very violent hiccup. Obviously, as you can imagine, this is a very delicate surgery, and if you have a huge hiccup like this every now and then under a microscope, it looks like an earthquake. So we waited 10 minutes, 15 minutes, the hiccups are not going anywhere. I consulted with my anesthesiologist, and he said, you know, I'm sorry, but even if I put him to sleep, the hiccups may not go away. So we decided to proceed with it, and I'm just going to show you this very quick, that's 1 minute video of what's happening. So I'm trying to make it and you can see here that sudden jerking of the eye. So basically, I adapted to the frequency of the hiccups. So I tried to wait here now. Okay, he already had one. So I hold this membrane and pull it, and then wait for the hiccup to happen. Now he has another one. Now I have my 2-3 seconds to actually do the next step, and then let go, because I don't want to actually have the hiccup when I'm holding the membrane, because I want to be in control of where it's going to go. So this was actually quite exciting, and at the same time challenging, if you will, because certain areas here, like here, I'm trying to grasp it, but I really couldn't. And he started up, so I was like, you know what? Let's wait for him. Let me not risk it. He did that. Then I just hold to it and try to finish this circle, because it's very important to finish this without any problems. Because if you do have any cut or anything like that, that's not a nice circle there, then you actually can get in trouble with the whole surgery. So as you can see, surgery is challenging, but also fun, and you have to improvise as you keep going. I would like to thank you so much for your kind attention and for the invitation, and I will be happy to address any questions that anybody may have. This is a picture of Moorfields Eye Hospital in London, and hope to see you or visit it at one point anytime. You are most welcome. Thank you so much.
Thank you so much, doctor. It was really very informative. It was very useful also, very informative, and so that a common man also can understand. So yes, we can start with the question and answers. If you have a question, you can unmute yourself and start asking the questions, and doctor will answer. We have 15 minutes more. In case if you're not able to answer all the questions, we will type out my email ID, and you can write down your questions. So does anyone have questions here?
Hello, sir.
Hi.
Hi, actually, there's a question from a French-speaking person. So I'm asking his question in English. So can you please answer? The question is about blindness due to intracranial tension treated by the installation of a ventriculoperitoneal valve, which made the side effects disappear without sight returning.
Yes. So this is a condition we did not discuss today, obviously, but let me explain as quickly as I can and as simple as I can. The eye sits in the bony sockets, and then there are two nerves that go behind the eyeball all the way to the back of the eye, to the back of the brain, I'm sorry, where the center of vision is. So the nerves get out of the eye and move all the way throughout our head to the back of the brain. So they are susceptible to any increased pressure in our skull. So any condition that causes the pressure inside of the skull to raise causes these optic nerves to get squeezed, which can cause you to lose vision or to have blindness. So in this condition you're talking about is a condition where unfortunately there is just an increase in the production of fluid that we have around our brain, and that squeezes the optic nerves and causes blindness. So what they do is they put a shunt between the brain and the abdomen, okay, the stomach, and that drains some of the extra fluid that's being produced around the brain into the tummy, and that gets away. So that relieves the tension and causes the vision to be restored.
Thank you, sir. Thank you so much. So, who wants to ask the next question?
I have a question. Okay. My name is Carol. I'm talking from Nigeria. I have a question for an obese patient with a BMI that is above 30, and the person is currently experiencing diabetic retinopathy disease. Is it necessary for the patient to have a weight loss procedure to improve his or her condition? And if the procedure is done, what kind of improvement will the patient experience? That's my question.
Excellent question. Excellent question. The weight loss procedures do not directly affect the diabetes effect on the eye. Okay, so what we call diabetic retinopathy. But one important factor you need to understand, for any patient who has diabetes in the eye, it is extremely important to control the blood sugar in order to preserve the vision. So how do you control the blood sugar? You control it by either diet, medications, or of course exercise. Or if you cannot really diet and you are BMI is very high, then at that point the role of surgery to actually reduce the weight and reduce the BMI becomes quite important, because that will allow your body and your regimen that you're using to actually control the sugar much better. So patients actually have better outcomes in all their body, including their vision and including their eye. So I have seen this actually. I had, it comes to mind, and thank you for reminding me of this. I had a very obese patient with a BMI of about 36 or 37, very, very high. Poor guy, he was just very, very obese. And we needed to inject his eyes pretty much on a monthly basis in order to maintain his vision. Then he disappears for 3 months and he comes back. I didn't recognize him because he's lost about 70 or 80 kilos and he looks quite different. He looks like a normal person now. And you know, much to my surprise, the swelling of the retina that I showed you pictures of had completely disappeared. And since then, it's been a year now, since then I have not had to inject him once. So I think there is significant importance to be given to weight loss in controlling the sugar, which will ultimately result in a much better control of diabetic retinopathy. I hope that answers your question.
Thank you so much, doctor.
Okay.
Yeah.
I also have a question.
Yes, sir.
My name is Dr. Patrick. I'm calling from Nigeria. Thank you very much, doctor, for this wonderful presentation. My question is on retinal detachment.
Yes.
You said it's an ocular emergency. I just want to know the time frame. For example, if somebody has retinal detachment today, how many days? For example, if you want to kind of send the patient to you to do the surgery, like how many days of grace do we have before this will have a bad outcome? Thank you.
Thank you so much, Dr. Patrick, for this question. Look, the answer will be based on two things. Number one, the science, and number two is practicality. Number one, science. So if we have someone that has a retinal detachment, like I said, if the macula, the central part, has detached, then we have time. But it's not a very long time. So we have about, I would say, 7 to 10 days, and we can get a good outcome. Now, that doesn't mean that if it's not fixed within 10 days, that the patient will be blind forever. Okay, so I have seen and operated on patients that have been detached for 2 months, 3 months, and they got a decent vision back. But those patients, unfortunately, we should not expect them to have excellent visual acuity. And we should not tell them that, oh, it's okay, go think about it. We should basically tell them that this is something that is, time is ticking. You need to do it as quickly as possible. But to be now more of a practical thing, because I know unfortunately we don't always have access to specialized care immediately, and sometimes you need to travel, and sometimes there is also restrictions for travel or visa or things like that. So from a practical standpoint, I would say as soon as possible, within weeks, not months, maybe 1 to 2 weeks, I think would be a good average time to say a good outcome should be expected from this.
Thank you very much.
Thank you, Dr.
Thank you, doctor. Next, does anyone have a question here?
Yes, please. Good afternoon, doctor.
Good afternoon.
Okay, I'm from Nigeria, so I have 2 questions to ask. One, what can a person do as a precaution to avoid having diabetic retinopathy? And secondly, it's related to glaucoma. And in the case of glaucoma, whereby the symptoms did not show at all, and it was discovered at later stage or late stage, and the diagnosis shows the nerves are being damaged. So in this case, can the nerves be can it be reversed, or a transplant has to be done?
All right, so to answer your first question about the diabetes, what can one do to prevent diabetic retinopathy? So I'm presuming somebody is diabetic, and what can they do to prevent diabetic retinopathy? And there are, multiple very important studies that looked at thousands of patients, and the number one factor that will actually prevent is control of the blood sugar by looking at hemoglobin A1C, which is checked every 3 months, and making sure it stays below, 6.5 or below 7, I think will be okay. So diabetes can be controlled. It cannot yet be cured, but can be controlled. And all the effect of diabetes, whether retinopathy or nephropathy or neuropathy, all the effects can be controlled by making sure that we don't let go of the sugar. Now, having said that, I realize and understand it is such a difficult thing to do because it's a lifelong problem. And I respect really people who are able to control it continuously, because it means that they have really to sacrifice a lot of things that they love to do or foods that they love to eat. Now, at the same time, there's no other thing you can do really. You can treat it once it's happened. The best outcome is to try to avoid it from happening by controlling the sugar. The second question about glaucoma. Glaucoma, unfortunately, is a very, very dangerous and sneaky condition because it has no symptoms. So when somebody has glaucoma and the pressure is elevated in the eye, they don't have any problem. And typically when people don't have any complaints, they don't go to the doctor. So if you don't have pain, you don't have redness, you don't have anything in the eye, you don't go see your eye doctor. While the pressure is inside of the eye, causing you damage in the optic nerve. So this is why it's very, very important if somebody has glaucoma family history, like somebody in the family with glaucoma, to go and check their eyes and make sure that they, if they have it, to treat it quickly. Because unfortunately, to answer the second part of your question, can it actually be transplanted? Can the nerve be transplanted, or the vision can be restored? Unfortunately, no. There is no such thing as retina transplant. There is no such thing as optic nerve transplant. When you diagnose glaucoma, all what you can do is to stop it from getting worse. But whatever you've lost, unfortunately, is permanent.
Thank you, sir.
Thank you, doctor. Thank you.
Mr. Mohammad Parvez has typed in a question. He has asked some anatomical reattachment can be just post-OP, but how long the psychological attachment can place? Mr. Mohammad Parvez, are you here?
Yes, I'm here. I
Yes.
mean, good evening, dear. I am asking anatomical reattachment can be within days or just after the surgery, but how long it take for physiological functioning of the attached retina, i.e. physiological reattachment?
Excellent question, Dr. Mohammad.
Thank you.
The retina, once you put it back in place, it starts to refunction again if it's not dead, meaning it hasn't been detached for a year or two. Once you put it back in place, it starts to refunction again, but not fully. So the first thing that the patients will tell you is that black shadow that I've seen before is now gone, but it's still not clear. Even after the gas bubble goes away or the silicone oil that we put in, we remove it, they tell you that I'm still not seeing good. Things are tilted. Things are, not straight. Sizes are different. So the person in my good eye looks a certain size, and then in my the retinal detachment eye, despite that it's not detachment anymore, looks a little bit distorted or smaller. Those are all the physiological things that Dr. Mohammad is asking about. And those are all of the things that will take time. And in my experience, it takes up to 1 year for things to happen, for the cells that were yanked out and then put back in again to find their roots and to basically find their connections to be able to give you that physiological improvement. But honestly, it takes about a year, sometimes a year and a half, until we say that the physiological improvement has completed.
Thank you.
Mr. Rakesh.
I have a question, sir.
Yeah, please.
Can I have a question?
Yeah, tell me, madam.
Hello, good afternoon. Can I go ahead?
Yes, madam, please.
Okay, I'm Rita from Nigeria.
Yes, ma'am.
I have two questions. One, is it possible to carry out a parotid surgery and there's still leftover of the cystics on the face? Then the second question is, how long does it take the swelling after surgery to go down? There is parotid surgery on a child of less than 2 years, and after the swelling.
I'm sorry, I didn't hear. What kind of surgery?
Parotid surgery, a cystic hygroma from birth. Cystic hygroma from birth. The doctor said he carried out parotid surgery on the face close to the ear. So after the surgery, there's still a swelling for over 6 months. So is it normal? Does it take more than 6 months for the swelling to go down?
I'm not sure I am qualified to answer this because parotid, I'm not sure exactly what is that related to the eye. I'm sorry, I'm not able to hear you well.
Madam, you can type in your question to us, write an email so that we can get it clarified.
Okay.
Iman, do you have a question?
Yes. Hi, sir. I am Iman from Egypt. I want to ask about can a patient suffer from both the cataract and glaucoma at the same time? And if it's matter, what's the most important to do first? Which operation most important?
Thank you, Iman, for this question. The answer, yes, it can coexist, cataract and glaucoma. There are certain conditions that actually, for example, there is a condition called pseudoexfoliation syndrome, which gives you glaucoma and cataract at the same time. But yes, they can. Patients who have, if you remember what I said in my presentation, everybody who lives long enough will get a cataract. So if somebody has a glaucoma and then they become 60, 70 years of age, they do develop also a cataract. Now, the question that you asked, which one is more important to treat? Typically, when we do the cataract surgery, the glaucoma or the control of the pressure gets better. Okay, so patients, mainly because of the thickness of the natural lens is thick and the artificial lens is thin. So it gives you a bit more room for opening the angle and improving the flow. But you can do two things. You can do them at the same time. You can do both the glaucoma, and if you have somebody who has an advanced glaucoma and a cataract, you can do them both at the same time. You can do the cataract surgery and do a filtering surgery at the same time if you need to.
Thank you, doctor.
Most welcome.
Thank you, doctor. I think we have passed 5 minutes than the scheduled time. Thank you so much for your time. In case if you have any other further questions, we will write it to you. And
Please,
I forward the questions to them. Really, this was a very informative session. Thank you, everyone, for taking your time and joining with us.
Thank you, sir. Thank you so much, and thanks for the opportunity again. And I hope it was useful to you.
Definitely, doctor. Thank you so much. Bye-bye.
Thank you for joining us for the webinar. For further queries, contact us at info@anavara.com or visit our website www.anavara.com.